Welcome, everybody. My name is Richard Horton from the Lancet, and it's my great pleasure and honor indeed to be your compere today for this celebration. Sadly, we're not in the Guildhall in London as we have been in the past, but we have created instead a truly international event rather than a local event with a limited attendance. This is the eighth, yes, indeed, the 8th annual Roux Prize. And we are here to celebrate the achievements of Dr. Zulfiqar Bhutta, the well-deserving recipient of this year's award. It's also an opportunity for me to offer personal thanks to David and Barbara Roux, without whom, of course, we would not be here in the first place. David and Barbara, your support for global health science is really deeply appreciated by the community. We have an extremely lively program for you over the next hour or so. We have videos about Dr. Bhutta's work and career and life indeed. You'll be able to hear from him directly in a seminar. We have several tributes to his work with a few questions, I hope, to put him on the spot from time to time. And a really special highlight towards the end, the award of the first Global Burden of Disease Emerging Researchers Award. Let me now hand over to my friend and colleague, Dr. Christopher Murray, Director of the Institute for Health Metrics and Evaluation. Chris, over to you.
Thank you, Richard. And let me add my voice to how exciting this is today to be here to celebrate Zulfi's incredible achievements and also to thank all the work that goes in behind the scenes to get to this point. Many, many nominations come in each year for the Roux Prize. There's a nominations committee chaired by Peter Piot who do the hard work of going through the many deserving individuals and eventually come through with finding a truly deserving winners as we have this year in Zulfi. The other thing that I'd like to mention is that Zulfi's planning to use the funds from the prize to further training and capacity development in lower and middle income countries. And I'm sure we'll hear more about that, but it's an extra special aspect to Zulfi's lifelong commitment to trying to make the world a better place. So congratulations to you again, Zulfi.
So now it's time to hear from David and Barbara Roux themselves, who have, of course, so generously endowed the Roux Prize in their name. So over to you, David and Barbara.
Thanks, Chris. First of all, let me echo the welcomes offered earlier. Thank you all for attending this year's awards ceremony. We're very excited to celebrate Dr. Bhutta's career and amazing body of work. His dedication to improving child and maternal health globally epitomizes the challenge of resolving seemingly insurmountable health problems using evidence-based techniques, the very same purpose that inspired us to establish the Roux Prize originally.
Zulfi, we are so pleased to offer our congratulations to you and our support as the winner of the 8th annual award. We would like to thank you for your tremendous impact on maternal, newborn, and child health. And we honor your championing of the community of female healthcare workers to take child and maternal healthcare to remote and very challenging locations.
As many attending can attest, your work with the Bellagio Study Group on Child Survival catalyzed renewed global efforts that led to millions of lives being saved. And the teams that you lead at the Hospital for Sick Children in Toronto and the Aga Khan University in Karachi have created a unique cross-national collaboration impacting child nutrition, maternal health, childhood pneumonia, and diarrhea. I could go on, but there are simply too many fields of study to mention.
When David and I created the Roux Prize, it was to honor people just like Zulfiqar Bhutta, people whose pioneering vision uses health evidence in bold ways to make people healthier. There could be no more deserving recipient. Congratulations, Zulfi, and thank you.
Congratulations, Zulfi.
Well, thank you, David and Barbara. Thank you so much for those words and indeed for your recognition of the importance of science as an instrument to advance the cause of the health of people worldwide. It's a very special moment, this particular time, and we do all want to salute your commitment. Now, we're going to hear from Zulfi in a few moments, hear a little bit about his work and career. But first, we have a video that's going to give you a brief introduction to some of the reasons why he's such a well-deserving recipient of this year's Roux Prize. So, over to the video.
You may want to look at the last 5 years of the MDG period.
Thousands of miles from his homeland of Pakistan, Dr. Zulfiqar Bhutta leads a team focused on improving health for mothers and children across the globe.
What you may want to do then is collect information on variables that you will need for that analysis.
He still remembers vividly the professor who mentored him when he first decided to pursue pediatrics.
Her first question to me was, well, what comes first? And I didn't quite understand at that time what she was talking about. And then the penny dropped. What she was telling me is that if you want to do newborn medicine, well, the mother comes first.
Thus began a lifelong journey, one that remains rooted in some of his earliest professional experiences.
I was exposed to some of the injustices, the disparities in services, the whole issue of women's empowerment, their status in society, and how we could do far better than what we were doing.
So where we are going is typical of the areas in and around Karachi. This is a very poor area, very low standards of environmental sanitation and hygiene, is water insecure, also has high rates of child mortality, morbidity.
At the time, most newborn deaths in Pakistan were taking place at home or as women traveled to a hospital.
Many of the disparities that you see are not just those between the rich and the poor, they're also geographic. So if you were to address those barriers, you would have to take the solutions to where people are.
Wherever births are taking place, absolutely every place you should train people.
Leading a research team at the Aga Khan University in Karachi, Zulfiqar Bhutta established a program of female nurse educators known as lady health workers. They visited women in their homes and villages, and the results were dramatic.
We had an impact on something that I never anticipated would happen. We reduced stillbirths by about 20%.
But such outcomes did not come easily. The lady health workers operated in communities with traditional customs and values.
ख़ास तौर पर माँ और बच्चे की सेहत के हवाले से हमारे बहुत पुराने ख़यालात के लोग यहाँ पे मौजूद थे जिनका माइंड चेंज करना हमारे लिए काफ़ी चैलेंजिंग था.
One such community is Mortality, a 2.5-hour drive northeast of Karachi. A small city of just over 20,000 people, Mortality is surrounded by fields of sugarcane and other crops. Nearby villages are home to agricultural workers and their families.
लेकिन अब जब मुझे 15 साल हो गए हैं, जब मैं देखती हूँ जाके, तो हमारी एक्सेप्टेंस हो गई है कम्युनिटी में. हमें लोग जो है वो सराहते हैं, हमें अपना समझते हैं, हमें अपने पास बिठाते हैं, अपने बायोलॉजिकल सैंपल्स हमें देते हैं और अपनी सोशल और इकोनॉमिक जो कंडीशंस हैं उनके हवाले से भी हमसे डिस्कस करते हैं.
For many women, the intervention of community-based health workers brought welcome change.
पहले हमारे गांव में इतना हमें तालीम नहीं थी, इतना शऊर नहीं था. जब ये आगा खान वाले आए हैं, लेडी हेल्थ वर्करों के ज़रिए हमें उन्होंने आगाही दी है. उनकी लड़कियां भी हमारे घरों में आती हैं और हमारे कद भी करती हैं और जी हमारा वज़न भी करते हैं, हमारे कद की नाप भी करते हैं ये लोग और हमें बताते हैं कि आपका वज़न कम है या ज़्यादा है. फिर और हमें बताते हैं कि जब मैं हमल से थी, जब मैं पेट से थी, कि मुझे क्या क्या खाना है, क्या क्या खुराक मेरे लिए सही है, सेहतमंद रहेगी, क्या क्या मेरे लिए ख़राब है, मेरे लिए सही नहीं रहेगी।
3 decades of research covering a wide range of mother and child health issues has produced remarkable health outcomes, remaining firmly based in the mission of the lady health workers to educate and inform.
त जीअं असां उन्हनि मसइलनि खे कीअं हल करे सघूं या उन्हनि मसइलनि जी असां कंहिं सां रिजू करे सघूं, जा असांखे इहा बि ॼाण मिली त अॻिते असांजी अज़वाजी ज़िंदगी जेका अहिड़नि मसइलनि सां जुड़ियल आहे, जीअं खोड़ सारी छोकिरियूं स्कूल वञनि थियूं पर उन्हनि खे इहा ॼाण नथी मिले, ऐं अॻ खां वञे त असां तमामु शुक्रगुज़ार आहियूं जेके अचनि था ऐं गॾिजाणियूं कनि था, उन जे बारे में असांखे ॼाण थी मिले।
The research findings of Dr. Bhutta's teams have impacted healthcare policy and practice from Pakistan to neighboring Bangladesh and Afghanistan to the republics of Central Asia, the countries of East Africa, and beyond. Along the way, he expanded his research into childhood communicable disease as well as the health of older children and adolescents.
It is this concept of the continuum across fetal life, pre-pregnancy period, young infancy and beyond that is now being well appreciated. However, we are quite far from having perfect solutions on how we address that within the health systems and in public policy.
For Zulfiqar Bhutta, it all starts with investment to address social disparities and in women's health and education.
Those 3 elements are the masala, are the mix by which countries can make that investment in a shorter period of time and will also have long-term benefits and gain the dividend of peace, because they are the ingredients of instability if you do not invest in them.
Whatever the future holds, Dr. Bhutta remains passionately committed to a vocation that he first acknowledged 4 decades ago.
What drives me is to see people improve their lives and livelihoods and to see that that can change. And I think the role of community health workers in low and middle income countries is a model for learning for high income countries as well. A reverse osmosis of innovation that was done at one end to reach the most marginalized. These are universal approaches that can be applied everywhere.
Well, I think that video really shows you why Dr. Bhutta is such a worthy winner of this year's Roux Prize. Now, in a moment, he's going to tell you his story himself, but I'd just like to inject a personal note here. And I'm very unbiased in what I'm about to say because I wasn't part of the selection panel for the Roux Prize. I'm simply your compere. But I've had the great pleasure and honor of working with Zulfi, if I may call you Zulfi and not Dr. Bhutta in the formality of this event, for 2 decades at least now. And I really do believe we've forged not just a partnership that's collegial, but a friendship that's based upon a respect that I have for your work, which I have seen make the most astonishing achievements, along with a whole team of individuals in what I might call the child survival movement. It's been a privilege for me to be an observer of the contribution you and your colleagues in Karachi and Toronto have made, Zulfi. And I just want to add my personal good wishes and thanks to you for what you have done for the field, and indeed, if I may say, for children and for humanity more generally. Zulfi, it's now your moment to tell everybody a little bit about your life story and how we come to be here today. So welcome, and over to you, my friend.
So thank you ever so much, Richard, and thank you for those personal comments, which are warmly reciprocated. And thank you, David and Barbara Roux, for this recognition, and to Chris for the leadership that you provide from the Institute, and for many who are joining today. I have been asked to cover a bit of my story, a journey, as I may, which I don't think is as yet complete, but it might provide some background as to why I ended up by doing what I did. And although I've been rewarded personally for this work, I'm the first to point out that the work is not mine entirely. And I would like to give due credit to the virtually hundreds of young people who have worked with me over the years. The reward is basically for their contribution. This is just a glimpse of the team that works with me in Pakistan. And some of these people have been working with me for upwards of 2 decades. So thank you very much for your support and for making it possible for us to achieve a little bit that we did in global health. Why does one get to do what one does in life? There are many drivers for this, but certainly your family and your background has huge contribution in that matter. And I want to start by paying a tribute to my parents. My mother, who is 93 and is probably watching this right at the moment, who was one of the first graduates in history from Punjab University, almost 70 plus years ago. And not only brought up a large family, but also provided personal tutelage, guidance, and support and inculcation of many of the values that still drive all of us today. My late father was an engineer who, at the prime of his career, gave up a lucrative private sector job to turn to education and set up technical education in some of the remotest parts of Pakistan, particularly in the Northwest frontier at that time where he belonged to. And I couldn't really understand at that time as a youngster as to why he was so singularly focused on opening institutions for young girls. Commerce colleges particularly focused on what he recognized as the promotion of parity in education. And this upbringing inculcated a large proportion of the values that still drive me and my team's mission today. I had a fabulous childhood, a happy, secure, loving arrangements. As the head of a brood of 7 siblings, I had all the privileges that come with being the eldest and also some of the responsibility. But growing up was fun. We moved through various parts of the country, but we also lived through troubled times. And as a young person growing in the 60s, and particularly experiencing college in the late 60s, you could not but be moved by what was going on in the world all around you. So I turned, as I said, left of left. And by the time I got to university, politics had assumed a much greater proportion of what I wanted to do in life. So much that at university, I started my own NGO, and there was every reason to suspect that rather than graduate from medical school, that I might pursue a different path at that time. And those who grew up in Pakistan in the late 60s, 70s might well imagine what a tumultuous period it was in the history of the nation. But graduate I did, and I graduated with a class which was not that of many privileged people. We had a number of my classmates who came from very remote rural parts of the Northwest frontier, now called the Khyber Pakhtunkhwa province. And I couldn't be more proud than of the classmates and female class fellows who are not in this particular image, who have been serving in many of the remote and important geographies of that province. I want to there were many mentors in my journey, and I don't have time to go through everything, but I would like to pay a particular tribute to somebody who had a huge influence at that early stage in my career. And it's important to mention her today because she passed away last Friday. So Professor Zakia Minhas was one of the first obstetricians and gynecologists in the Khyber Pakhtunkhwa province, a phenomenally talented and well-rounded individual who served in many medical administrative roles. And for some reason in medical school, she virtually adopted me as a mentor at an early stage and knew that I wanted to do newborn medicine. And And when after graduation, I went to see her and said, "Madam, I want to ask what I should do in terms of a selection of house jobs, because I had a choice." She didn't hesitate for a moment to ask me to start with learning a bit about the mother. And that's how I ended up by working with her at a very early formative stage of my career. And I can tell you today, nearly half a century on, that was one of the best decisions I ever made in my career, is to start with doing maternal health, because that has forever inculcated the importance of the mother-baby dyad in my mind. Well, I went, like many others have done before me, I went to the United Kingdom to train, and I trained in neonatal pediatrics in some of the teaching hospitals, best teaching hospitals of the country in the southwest in London. And I duly returned to Pakistan in 1986 to the premier teaching institution in the country at that time. It was just beginning. And Dean Adil Haider may remember being from one of the first classes, what heady times they were. And it was not only just the beauty of the campus, but the opportunity of working with a new mission to improve medical education, training, and service in the environment that we lived in. And I was able to set up, as I mentioned, newborn services at the Aga Khan University Hospital, which were largely of a tertiary nature, given a city with almost 20 million population. Not surprisingly, in the first few decades of coming back to Pakistan, the work largely revolved around clinical hospital-based research and a fair amount of laboratory-based element added to it. But it wasn't sufficient. And by the early 90s to mid-90s, it was very clear to me that in order to influence things outside of the wonderful island that we were working in Pakistan, that one had to step out of the four walls of the institution to do something different. And that also meant that you had to have a leap of faith, and you had to start things that hadn't been imagined from a clinical service delivery platform before. So one of the things that I at least set up a small group to try and do at that time, given what little we knew about research to policy pathway, was to try and set up a small but focused center for evidence generation and evidence synthesis. And this was how I got into public health demographics and understanding what the dimensions of what we were trying to do were in relation to the problem at large. In a country of 200 plus million people, how could one small institution make a difference? So in the first few years, we spent a lot of energy on just generating the information to inform ourselves and to inform others in terms of what mattered. This graphic that I show often, generated over 2 decades ago now, took us several years to compile because it was a compilation of newborn mortality trends in Pakistan. And what it showed very clearly, even at that time, was that this was a problem that had not been addressed. And as a result, the whole mortality patterns had stagnated over time. We also began to look at differentials or differences in various parts of the country. This graphic again took us a long time at that time to construct because there just wasn't enough information at subnational level for things like drivers. This is a district-based graphic of multidimensional poverty index, which the Lancet chose to publish as part of one of our national compilations, but it took a long time to generate because it required a lot of data triangulation. But once we had done it, it was very clear that we were dealing with not just one country, that we were dealing with a very disparate country with tremendous diversity, tremendous differentials, and by default, tremendous inequity. I also did one of the first studies at that time of trying to understand newborn mortality in relation to the health system. And the health system in Pakistan, friends, was a very dynamic system with a lot of tiers: basic community health, village-based health units, rural health centers, and tertiary apex hospitals, where a few lucky managed to go. But when it came to service delivery and care seeking in this health system, people typically voted with their feet. They either made their way to the large apex urban hospital, or they stayed where they were. And as a result, we discovered that the distribution of newborn mortality in the districts that we were working in was sadly, with the vast majority being at home, some making their way up the health system, and a few dying in the process of seeking care. And this was one of the reasons why we moved very quickly, once we began to recognize this, into community-based research, initially just by data demonstration and looking at evidence generation of the kind that I've just mentioned to you. And as an immediate byproduct of that work, we got what we hadn't anticipated, a significant amount of global attention. And I want to call out now almost 2 decades ago, when I first received an invitation from Bob Black, who I'm very pleased is on the call today, to join his group in the scenic town of Bellagio to look at how child survival was moving worldwide. It was a bit of a surprise because we were picked up, perhaps Bob, you may ponder on why, because of the work that we had begun on looking at newborn survival and newborn mortality in a low middle income country. But this was the turning point, and hence the importance of collaboration. We couldn't have done what we have done without that interface and without that learning from other people and people who are looking at this from a global landscape. A phenomenal meeting, rest is history. You don't see Richard Horton in this slide, but Richard was very much there, both in letter, spirit, and in person, and he had just left before this group was taken. But the result of all of that was that we did get into the space in a big way, and from the university, hospital, and academic center in Karachi, we produced one of the first systematic analyses of community-based interventions to reduce newborn mortality. And this was published as a big supplement in pediatrics and received a lot of attention. It also received the attention of the Lancet because I was asked to lead a group of people to develop a systematic analysis of interventions for newborn survival in the year 2005, in partnership with Joy Lawn and colleagues like Gary Darmstadt. And we looked at a number of interventions that could make a difference, in theory, to reducing newborn survival, especially if they were packaged together into packages that could be delivered at scale. And so we did. We developed these packages that we put out in terms of their impact and put out also in terms of their relationship to mortality reduction in various parts of the world. So this foray into global health was not only rewarding, it was a huge learning opportunity. But unanticipated in many ways, it also opened the doors to influencing national policy, which is not necessarily a linear relationship. In our instance, it wasn't that the policymakers in the country noticed us first. It was when our work was recognized internationally that we got invitations to go to Islamabad and talk to people in terms of how things ought to change. But it was clear that we needed to do more. And the reason why we needed to do more was that in order to influence health, one needed to take the theory into practice. And we recognized that we had to work on translational research. And some of the work that we did as part of the Lancet series was exactly to try and see how we could translate. But it was also very clear to me, particularly from the group that I was working with and in, that just generating these research papers and these reports was never going to be enough. So we had to do something in particular in terms of influencing national policy, and that was never going to be through research reports only, and required an interface with government in terms of implementation and in terms of translation into policy. And that required moving into the field with some practical field sites where we could test some of the evidence that we were generating in actual real life practice. And we had to choose a rural field site where we could begin to test the waters. And the rural field site that we chose was a site about 2.5 hours outside of Karachi, a field site of Matiari, which is a rural district of Pakistan with features, external features, quite like that of many agrarian populations in the country. And we were able to set up our own field station, which now, after many years, is owned by the university. It's on the university's own land and is a research and training center. And the big question there was, who do we work with? And what I chose at that time was to work with the primary care program of the government. There was a big controversy within the group as to whether we should work with government health workers or have our own health workers because we couldn't control them. And we chose to work with the government's Lady Health Workers program, largely because it was the public sector program, which was at scale and influenced a lot of the primary care at rural population level. And one of the hypotheses that we set ourselves is, could we work with this program to improve neonatal mortality in rural Pakistan? And the first cluster randomized trial that we did, with a fair amount of collaboration and support from the World Health Organization, was in about 1,400 villages and a large population, rural population, with a focus on, number one, supporting communities to interact amongst each other and support lady health workers, and secondly, the lady health workers working with families and communities in assessing, analyzing, and improving newborn care. And the results were phenomenal. We saw a massive improvement overall in antenatal care, in the use of clean delivery kits, which we didn't provide ourselves, in breastfeeding, breast milk administration after birth, and importantly, in indicators that we never really anticipated would change. So, for example, to see the gains in stillbirth reduction and perinatal mortality, we hadn't put a new set of health workers in that area. It wasn't very clear why that should have happened, but it did. And the penny dropped when we saw that it had happened largely through an improvement in facility-based births in that area and care-seeking patterns, which have remained to date. And that, ladies and gentlemen, gave us the confidence to work with this national health program, Lady Health Workers. And we have, in this and other areas, worked not only with women in that population, we have worked with their mother-in-laws, we've also worked with young people, with adolescent girls. So it is possible to work at scale with the government program and influence different things. Now, I don't have time today to go through all the sequential, large cluster randomized trials that we've done. Our group has been fortunate to be involved in over a dozen such large cluster randomized trials in various parts of Pakistan, some in even conflict areas, and all requiring a lot of resources and time. Now, many people recognize the success that we have had with some of these trials. Few people appreciate the hard work and the failures, and sometimes the unanticipated results that you get from some of those experiments that have been probably greater learning value than some of the positive studies that we have had. And all seemed to be going well, except for the one recognition that I had, that much of the implementation work that I was doing was limited, given the limitations and difficulties that you have of doing this outside of a developing country. So about 11 years ago, there was another leap of faith. And then I managed to persuade the university leadership to allow me to shift my base to Toronto, Canada, and to try and see if I could manage a joint program, which we have since then had through the Center for Global Child Health. I've been very grateful to my second home, the Center for Global Child Health at the Hospital for Sick Children in Toronto, because we were able to create a phenomenal body of young people who've been involved in various issues of global health. As you can see from this group, which is from a few years ago, they represent various geographies. And the advantage of working with this group here from Toronto was that we could take things to a different level that was very difficult from just one platform of a university center in Karachi, to take it to both doing things at scale across various countries, monitoring and evaluation. So one of the first things that we developed after that move was to move into a large scaled up project funded by the Gates Foundation to look at 12 districts in rural Pakistan. This big New Hope project is now reaching its conclusion in a couple of years, and it has given us an opportunity to look at a population scale which is several folds greater than before. It has also allowed us to move into different geographies. So from the base at Sick Kids in collaboration with AKU, these are the geographic areas where we have worked in, both in terms of country case studies and looking at models of implementation over the last few years. And that's been a hugely important aspect of our work. We've also taken on difficult topics. So again, as in collaboration with the Lancet and with many other members of academic centers, we were able to go into an area that nobody had treaded in before, which is looking at women and children's health in conflict settings and emergencies. And as part of this branch series work, we've undertaken a large number of country case studies in many conflict-affected areas, which I did not think was possible at one stage. So, ladies and gentlemen, I started off by titling this as an odyssey, as a journey, which was an extended adventure. It indeed has been. And it's also been a great learning opportunity, an enjoyable opportunity to work on different areas. As I told you, I started off as a card-carrying neonatologist who saw the light and moved into public health, but also very soon recognized that even newborn care is just a very limited part of what we do, and that to look across the continuum of child health, working across school age and adolescence, working on issues that affect population health like climate, socio-political, economic consideration, this is all part of a learning exercise. And now at this stage of my career, in the twilight of my career, I've begun to learn much more about these things and begun to enjoy working on areas that don't necessarily fall into my disciplinary expertise. Let me end up by saying that the greatest partners in all of this effort have been my family and my dear wife, who as an independent academic has been my thought partner and my soulmate over all these years. Without their love and support and affection, I could not have achieved even a fraction of what I was able to achieve. Thank you very much for your attention, and I look forward to further interaction. Thank you.
Zulfi, that was absolutely fantastic. Thank you so much for blending insights into your biography, your personal biography, with your professional life. I think the whole story really came alive there. Thank you very much indeed. Now, joining us, we have a highly distinguished panel who are going to offer some comments and reflections themselves. We've got Dr. Samira Asma from the World Health Organization, and we also have Dr. Adil Haider, who's the Dean of the Medical School at the Aga Khan University. But first, we're going to have somebody who Zulfi has already mentioned, a co-conspirator in this revolution we've seen in the past 20 years. It's a real pleasure to introduce Dr. Bob Black, who's chair of the Johns Hopkins School of Public Health. And Bob, you saw him in the photograph at the Rockefeller Foundation in Bellagio. Bob has been a true leader in his own right, as well as a colleague with Zulfi. So Bob, over to you, my friend.
Thank you, Richard, for giving me an opportunity to comment on a close colleague, as you say, maybe co-conspirator and friend for more than 2 decades. And thinking about a phrase to encompass what I know about Zulfi's career, Renaissance man came to mind. But of course, I had to change that to a more gender-sensitive Renaissance person. So that's not to say he's a 15th century European or a great artist, at least as far as I know, but that he does have many attributes of a Renaissance person in global health. The first of 3 attributes that I will mention is his breadth of scholarship. His research began, and you heard some of it, but it's even broader than he had the opportunity to present. It began with neonatal infections and pediatric enteric diseases, and we crossed paths in those fields, of course, but expanded to encompass childhood undernutrition and micronutrient deficiencies, expanded again to include maternal and adolescent health, and further to include the effects of conflict, the COVID-19 pandemic, and the importance of poverty, justice, and equity. A second attribute is his depth of scholarship. Zulfi has a deep commitment to improving child survival, health, and development. And this is manifested by his innovative research in Pakistan on health and nutrition interventions for children, especially those, I think, that are delivered by community health workers and public health approaches, as he mentioned, and also by his ability to synthesize knowledge on interventions to improve child health, including by leading many systematic reviews. He is one of the world's most prolific and influential authors and advocates for children. With more than 1,000 published papers, there are few, if any, global health practitioners or researchers who have not read and cited or acted on his work. There are some good examples of his evidence-based advocacy over the past 2 decades, as he mentioned some, including a series of papers in the Lancet, including those on child survival, neonatal survival and health, stillbirths, maternal and child nutrition, child development, primary health care, the effects of conflict, and even another one coming early next year on optimizing child and adolescent health and development and building human capital. Another example of his influence is that his team wrote a third of the chapters in the Disease Control Priorities 3rd edition volume on reproductive, maternal, newborn, and child health that I edited. He has been able to link information from different areas and create new knowledge, as well as galvanize global action. A third Renaissance attribute, of course, is humanism. Believing, these are my own parts of the definition of humanism, believing in human potential and seeking knowledge for the common good. As you heard, Zulfi has built teams of students and young researchers in Pakistan, in Canada, and more broadly through collaboration in Central and South Asia and in Africa. Through his leadership and mentoring, he has advanced the careers of the next generation of scholars in global health. To ensure that the evidence on how to reduce the disease burden of children turns into action, he has worked tirelessly on international commissions, committees, and initiatives to promote equity and the welfare of children. This work has directly led to the adoption and implementation of important policies and programs focused on child health, nutrition, and development at both global and national levels. In addition to his breadth of scholarship and humanism related to global child health, Zulfi is a considerate and caring colleague and friend who is devoted to his family, including his wife, Shireen, his children and grandchildren, and of course his mother, all of whom I've had the pleasure to meet. His receipt of the 2021 Roux Prize is an extremely appropriate choice, and I offer my heartfelt congratulations. And so now I think I have an opportunity to ask a question. So Zulfi, are there lessons from the global response to the COVID-19 pandemic that will enable us to respond better to the needs of children in the future? Thank you.
Oh, thank you, Bob. I didn't see that coming, but it's a hugely, first of all, thank you so much for those kind words. Bob, they mean a world coming from you in particular, because I've learned so much from you over the years. And thank you for your collegiality and for your mentorship, if I may say so. So yes, of course, I think one of the biggest things that have emerged from COVID-19 is the huge relationship that the disease has had with outcomes in relation to existing socioeconomic and societal disparities. Not only have those been hugely important in high-income countries, but they are also there in low and middle-income countries. And everywhere in the world, we have seen how these inequities have fundamentally affected global health. Today, we are facing an onslaught of variants of concern. And a major reason why we have these variants of concern is because the response has been so unequal. But in children, as I have mentioned, and through the work that we've done in South Asia, there has been perhaps a misunderstanding from the get-go that children were not affected to the same extent as adults. They have not been the focus of attention of interventions over and beyond closing the schools, which I think have had the opposite effect to what was intended. But the indirect effects of COVID-19 on children have been phenomenal. And they have been of a nature that could have potential intergenerational effects. So I'll only mention a few to say the loss of education and the loss of learning at a critical point in time to a whole generation of children is something that concerns me deeply. It concerns me as a physician, as a public health practitioner, as a grandfather, because my own grandchildren have been affected by the loss of ability to partake of education and learning at the critical point in time. The second has been what has happened to them in health systems and the disruption of services, both direct and indirect, both by poor care seeking and also by care provision, has had a huge impact. The effect of education disruption for young girls in particular in parts of the world where the only difference between an early child marriage and a girl going on to a career and development of her own human capital and potential has been the fact that she stayed in an education system. And once you take that away from families, and if for nearly 2 years now, if girls have been out of school at the age of 16, 17, 18, you can well imagine what that does to early marriage. And it worries me considerably that that's happened in large numbers. Mental health consequences of living a very artificial life. A number of people ask me, why do you speak about childhood vaccinations? Well, the reason for childhood vaccinations is not just to overall provide protection, but also to restore some semblance of normalcy to a whole generation that has not had functions, social interaction, birthdays for several years. You can imagine what an important part of growing up that is to child development. So, Bob, this is something that we need to consider. And I think now, having done the diagnosis, a lot of my group's work is focused on what can we do to build back rapidly, fairly, and importantly, sustainably, in a way that we learn from this pandemic what should never happen in the next pandemic. Thank you.
Thanks very much, Zulfi, and thanks, Bob, for your lovely words. Let me turn now to Dr. Samira Asma, who is an Assistant Director General at the World Health Organization, responsible for data analytics and delivery for impact, which is exactly the subject of our hour together today. Samira, it's wonderful that you can join us. Thank you very much. I know it's a busy time at the World Health Organization. You're in the eye of this COVID storm still, but thank you for joining us to offer a few words about Zulfi. Over to you.
Thank you so much, Richard, and thank you for inviting WHO. And I would like to congratulate Zulfi on behalf of Dr. Tedros and Soumya Swaminathan, who could not be here today. And I had the privilege to step into her place. And the entire family of WHO, heartiest congratulations on receiving the Roux Prize. I would like to begin by thanking you for your impressive and impactful contributions to WHO. You have served in so many ways on so many committees and advisory groups, and your work has really advanced not only the evidence base through the guidelines, but it has truly made an impact in the area of RMNCH. Pandemic has shown what is local is global and what is global is local. And your career throughout, you have been a problem solver, and you have really tackled one of the most stubborn problem, which is reducing disparities. So my question to you is that you mentioned primary health care and the work you have done where you've brought primary health care as a centerpiece to advancing universal health coverage. We recognize that the Sustainable Development Goal indicator that tracks universal health coverage is inadequate. And I would like to hear from you what advice you would have for WHO as we move forward, taking lessons from the pandemic, and how do we improvise so that we can truly and effectively track and close this divide of inequalities as we go forward. Thank you.
Well, thank you so much for those thoughtful comments, Samira, and recognizing WHO's leadership for the voices of the poor throughout this pandemic WHO has been unafraid to say things that needed to be said for global equity, for particularly vaccine access. And Dr. Tedros has led the field in putting his own position very clear from the very get-go. Now, turning to universal healthcare, I have been unafraid to criticize where I think some of the shortfalls in the current measures are, and the current indicator does not do enough justice to child health or the continuum within it, but it's a starting point. So what I would hope now that will happen is that as we emerge from this and begin to get into real data collection from routine health information systems and monitoring how we recover, that we would take into account things that we know from the pandemic are major influencers on child, adolescent health, maternal health writ large, that are not part of those indicators. So take mental health as an example. I mean, all of a sudden, the realization, wow, that the biggest impact that we have had out of COVID-19 on families, children, and adolescents around mental health. And we have very few measures out there as to what is happening and also what can be done at primary care level. So Samira, I would say that we need a discussion and a discourse on how we can emerge from all of this with a better recognition of gaps and what can be done to plug the gaps. Now, yes, we had coined the UHC indicators and also to some extent the SDG indices in pre-pandemic times. But it is up to us as scientists, as public health individuals, to revisit those in 2022 and see, can we improve upon them? Nothing is cast in stone. This is not a trial where we have fixed all the indicators beforehand. Yes, we will report back on those by the end of the SDGs, but this is time to now sit down and say, what should we be measuring, both in terms of our rebuilding process and what should we be measuring in terms of improving our current indicators? I know, just to finish, Samira, I know there was parsimony in the indicators when we were building the UHC tracking indicators. But I think at times, the parsimony does not mean that you pick up the least common denominators also. It is time for us to have a discussion with countries who are interested in seeing how can we improve the lives of children and families over there. And if inequities is the biggest gorilla in the room right now, then let's go and measure inequities by means that are more robust than just looking at socioeconomic gradients. If ethnicity is a big difference between those who receive access and otherwise, let's measure those. Let's measure geospatial differentials. So those kind of things are important to discuss in the context of what needs to be redone, both in terms of selection of indicators and how we are going to measure them in making a difference. Thank you.
Thank you.
Thanks very much, Zulfi. Thanks so much, Samira, for your comments and question. Our third panelist today, it's a great pleasure for me to introduce Dr. Adil Haider, who is two roles that I'm going to cite as Dean of the Medical School at the Aga Khan University, but also Director of Disparities in Emerging Trauma Systems at the Brigham and Women's Hospital. Adil, it's great that you're with us. Thank you so much. The floor is yours.
Thank you so much, Dr. Horton. In a word, Zulfi is an inspiration. And I don't say that lightly. He really, really is. And I can, before I get to why I think so, I also want to thank the organizers of today's event and those who have endowed the Roux Prize with the fact that it is so important to do these kinds of things and these kinds of events so that people can see why somebody is honored with this kind of an award. Like, what does it take to have this impact? And how can we continue to inspire more and more people to lead the kind of life that Professor Zulfiqar Bhutta has led in the service of medicine and humanity? I know this well because I first met Zulfi not as a student, not as a colleague, but actually as the brother of a little kid who had just been born. I was 16 and a half when my youngest brother was born, and he was admitted to the neonatal intensive care unit. where a young Dr. Zulfiqar Bhutta took care of him. And till this day, we know that he saved him. And we know that he is a hero for all of us in our family. And in fact, when I became dean, the first thing Zulfi asked me was, how is Ahmad? How is he doing? And that just tells you that he remembered a patient from more than 28 years ago. Just goes to tell you what kind of guy Zulfi is. Now, after that sort of personal story, I got to tell you, as Dean of the Medical College at AKU, I've had the chance to see Zulfi in many different roles. First, I was a student, as Zulfi mentioned, in the 90s, when he was had just built the first NICU there and was launching this incredible career that you've heard about. And then, of course, I've got to have seen him when I was training as a surgeon overseas and when I worked overseas. We saw the incredible work that he did. And I could tell you 3 specific things about Zulfi and what leads to the prize today. The first thing is that he focuses on building systems. He became the chair of pediatrics, then realizing how we needed to have impact beyond the beautiful pink walls. And you saw the Khan University, how amazing and beautiful it is. But he wanted to have impact in the field. So he created the Center of Excellence in Women and Child Health. So this focus on building systems that will, go be far reaching, I think is one of the main things to learn from Zulfi's incredible career. The second thing, and I'm sure everybody on this call knows this, is Zulfi has just an incredible work ethic. There is no email that doesn't get a response. There is nothing that is ever late. And then there is nothing that is ever done that's sloppy. Everything is done extremely well. And the impact this has on the young investigators, the people who work with him, the people who realize the standard he sets, and the people who emulate him really makes a difference. And that's why I use the word inspirational with no worries. And then finally, and I've sort of come back full circle to where I first met Zulfi, to be a good clinician scientist, you have to be a good clinician. You can't just be a scientist. And Zulfi is still the person that people will call when they have a difficult case. Zulfi is still the person that people will look up to and bring complex problems to for a solution. So I know, Dr. Asma, you called him a problem solver. He is an incredible problem solver. And we've seen what he's able to do with his patients and the profound impact he's had on researchers, on patients, and the impact that he's had at the university, at Khan. And then, of course, we're so thrilled that we could continue working with him when he went to Toronto. And then, of course, now he leads the IGHD, the Institute for Global Health and Development, which is the next big chapter, we hope. So when Zulfi said that we hope his chapters are not complete, we were thrilled to hear that, because we still think that there's a lot more than women and child health where we're going to see Zulfi's contribution. Now, my question, if I still get to ask one, I know, is that okay, Richard? Can I still ask a question? Zulfi, you called it an unjust world. But I got to say, for all the unjust that there are some bright spots. And I know you count your bright spots by your trainees. In this generation, as a very senior male identifying professor, tell us how you work hard to ensure that you have and you showed the pictures already. We know you have an extremely diverse group of colleagues that you work with. How do you mentor and propel the careers of all the diverse colleagues that you work with? And I'm thinking of Shabina Arif and Faiza Jahan, all these great investigators that you've supported.
That's a fantastic question, Adil, and worthy of a much more thoughtful response than I may give you off the cuff. Well, what I can tell you is that both in Karachi as well as in Toronto, the one way of doing that is to actually practice what you preach. And therefore, at AKU, we were amongst the first. And when I say we, I absolutely mean my colleagues, both my peers and juniors who worked with me. Remember, I never did anything alone. And in the building of the Center of Excellence and the Department of Pediatrics, the contributions of many now world leaders like Anita Zaidi, strong clinicians like Iqtidar Khan, Dr. Nizami, and others must be recognized. So from a very early point, the whole issue of ensuring that we created a level playing field for women in medicine was extremely important. We were amongst the first to create a flexible training program and to ensure that both in our recruitments and also in terms of our training, that we provided ample opportunities, irrespective of caste, color, creed. So my program has always had minorities in it because we've just generally been blinded to it. Here in Toronto, we have people from all descriptions, first generation, second generation, Canadians, people who come from Africa, from the Middle East, from the Caribbean. And the importance of working together in that kind of an environment is that it just creates the mixture around which collegial relationships and scholarship are built. I know that we have always better things to learn. So we are, despite all the things that we do, we are still learning about equity, parity, gender-related issues, and initiating a series of deep dives into it. But just to say that one of my missions, and it's actually a next series of steps that we are undertaking, is to ensure that we promote women in science. In a grant that I have received recently from the Bill and Melinda Gates Foundation, the focus at AKU is going to be to recruit early career and young female scientists who are working in reproductive health, maternal health, issues of epidemiology, issues of child health, and provide them the mentorship and support over the next 3 years so they can strengthen their credentials through both a linked mentorship program as well as resources for research. I think something like that, even though we are acting as a facilitator, is one of the strongest initiatives you could build in science. So I think it's extremely important for us to build the critical mass of people who can do this, who are not just a single individual like myself, but a whole group of people who are focused on doing this. And remember that we are an island within an island, that although Aga Khan University exists as a center of excellence in Pakistan, but we have the need to do so much more in provinces. And I hope that now with your leadership in the Pakistan Medical Commission, that might also happen.
Thank you very much indeed, Zulfi. Thank you, Adil, for your comments and question. Now, of course, Zulfi still has a considerable task and challenge ahead of him, as we've already heard. So he's still in the middle of his career. But what you have heard today is something of a summation of life's commitment. I'd like to turn now to a slightly different emphasis, but no less important. And it's really inspirational, actually, that we are able to announce for the very first time this Global Burden of Disease Emerging Researcher Award. So let me immediately hand over to Dr. Chris Murray, who's going to tell you a little bit about this award and about the winner. Chris.
Thank you very much, Richard. I am very pleased that we are awarding for the first time this year the GBD Emerging Researcher Award. I was fortunate enough to win a prize a few years back and able to devote those funds to creating this award. So we will be giving this award out on an annual basis. And we have a separate nominations committee, and I fortunately have nothing to do with the selection, but they did their due diligence. And the winner of our first GBD Emerging Researcher Award is Leopold Aminde, a Cameroonian physician working in Griffith University in Australia. And because of the time change, he's not able to be here live. But a few days ago, I had a very interesting and actually inspiring conversation with Leopold. Well, it's a great pleasure to meet you, Dr. Aminde, and it's also a great pleasure that you are the inaugural recipient of the prize that I was happy to set up for to recognize emerging GBD researchers. So I'd love to hear a little bit about how you came to do your work on cardiovascular disease and other topics that you've been pursuing.
Thank you very much, Chris. It's a pleasure to meet you as well. And my story with cardiovascular disease and global burden of disease dates back to around about 2014-15, when I had just finished my medical training in Cameroon. And, you know, working as a clinician in the first hospital where I was posted to. So quite a few, a variety of people with different disease conditions. And I began to ask myself a number of questions that, okay, how many of people can afford coming to the hospital? Because this was a tertiary hospital I was fortunate to work in. And I thought about, okay, what about those who are unable to afford this care, those in the district hospitals? And what about those in the communities who can't even, who aren't making it to the hospitals? So looking at that, I began to think, okay, how do I implement the passion to help people as a doctor? I was like, how can I expand this impact beyond the hospital and into the communities? And I was like, okay, and if I had to do that, I also needed to understand which conditions were causing the most, problems in the community, and that was taking away lives as well. So I thought, well, perhaps I might have my answers by engaging in some research. And that inspired me to then start thinking about pursuing a PhD. And when I began to engage with the literature in this, preparing my proposal for my PhD application, then I stumbled on the global burden of disease studies. And these already provided quite some answers to the questions I was asking as a clinician, and providing this comprehensive information around, which diseases were causing the most problems and the most deaths, and prioritizing which ones, if I needed to do something, could have the most impact. So that's a bit of the inspiration from the beginning and how I engaged with the global burden of disease studies.
And I understand that you're expanding your scope from not just Africa, but looking in Asia as well. So where do you see your work going in the coming years?
That's correct. As you very well know, the burden of cardiovascular disease, or NCDs, is really growing in the low and middle income countries where most of these premature deaths are occurring. So I thought to focus my work in helping this sort of low-resourced settings, beginning first in Cameroon, my birth country, and then, as you rightly said, expanding to Asia, which in my current postdoctoral research, I'm expanding to Vietnam and Indonesia. And hypertension is what I've identified as one of the leading and largest risk factors for this cardiovascular disease burden. And so I'm sort of looking for which simple interventions, can address high blood pressure. And so that's what inspired me in the direction of dietary salt reduction as a simple and cost-effective strategy potentially to address hypertension. And so that's how my work progressively expanded in that direction for dietary salt reduction and blood pressure, and of course the complications that we all see with strokes and heart disease.
So I have one more question for you, Dr. Aminde, and that is, if you had to say anything to other early career researchers, what would be your bit of advice for them, given your experience so far?
If I had some advice for them, I think it's going to be patience and resilience, not giving up. Because along my journey just beginning, I've had quite a few pushbacks. For example, writing a paper and you submit to a journal and it gets rejected and those kind of things. So not to get discouraged, but to keep on and stay resilient, stay focused, and hopefully something will come by. And so I'm very grateful with this award, as it comes to encourage me along this journey and hopefully inspires other young researchers as well that this is possible.
Well, the bad news is that we all continually get rejected throughout our careers, but as hopefully we win more than we lose. It's a great pleasure to meet you, and congratulations on being the inaugural winner. There will only be one of you, but more to come in future years. Thank you so much for your work today.
Thank you very much, Chris. It's a great pleasure, and thanks for inspiring this award.
Well, that was a wonderful moment, and real big thanks to Chris, and a special congratulations to Dr. Aminde for winning this inaugural GBD award. It's a great addition to today's event. Zulfi, I know you had a comment to make on this award too.
Well, thank you, Richard. I just wanted to add my word on behalf of the committee, the selection committee that I had the great honor of chairing. Dr. Aminde, congratulations again. And I think not only does the awards recognize your unique contributions to this space, but I hope that this will encourage others to come forward and for you to continue your good work, not only in the context of where you are right now in your country, Cameroon, but also in other parts of the world. So thank you very much for your scholarship, and congratulations again. Back to you, Richard.
Thanks, Zulfi. Well, that concludes our hour together to celebrate the Roux Prize for 2021. Please join with me in wishing a final congratulations to Zulfi for this award. Also, thank you to our wonderful panelists, Bob Black, Samira Asma, and Adil Haider for their comments and incisive questions. Thanks to Chris and the whole team at IHME and the team behind the scenes at IHME for their work. A lot of preparation goes into an event like this. So I'd like to thank Kelsey Bannon and Tim Exton and the whole team, and also the group at Evia Events who've made this possible. Please stay safe. We live in a dangerous world, and everybody on this call I know is working hard to make our world a more secure and better place. So stay safe, everybody, and thank you very much once again.